Hello everyone, this is Dr. Hashem Abu Serhan. I will talk today about hydroxychloroquine or Plaquenil retinopathy, or what's known as hydroxychloroquine eye toxicity. This is one of the common pictures seen fundus autofluorescence image of hydroxychloroquine retinopathy. First of all, hydroxychloroquine, Plaquenil, or chloroquine derivatives in general are commonly used in the treatment of malaria. They are firstly were FDA approved for malaria. Then they were used for rheumatologic and autoimmune diseases like SLE, rheumatoid arthritis, antiphospholipid syndrome, and primary Sjogren's syndrome, and others. And also they are used for dermatologic diseases, and we will explain why that. Also, the hydroxychloroquine in the recent decade was considered for DM, heart diseases, and even as adjunctive therapy for cancers. All of us remember that during COVID pandemic, hydroxychloroquine was very common in the treatment for COVID-19 patients as off-label use. This is a historical flow diagram for chloroquine's derivatives in general. As we see here, that chloroquine was first synthesized in 1934 and was FDA approved for medical use in 1949. Also, hydroxychloroquine was first synthesized in 1950 and was FDA approved for medical use in 1955. So they have been used for a very long time and for decades for many diseases, especially for the malaria. And why they are used? Because RCT's randomized clinical trial showed strong evidence that hydroxychloroquine, Plaquenil, has immunomodulatory capacity, which helps in preventing disease flares and promote long-term survival in SLE, and also control autoimmune disease activity during pregnancy without evidence of phytotoxic or embryotoxic effects. And also it can help in delaying or preventing organ damage like bone destruction seen in autoimmunity. Also, many reports mention that hydroxychloroquine has antithrombotic effects, and we know that autoimmune diseases like antiphospholipid syndrome or others can have the pro-thrombotic events. So it has antithrombotic effects. That's why these all benefits of hydroxychloroquine, that's why it's very popular in the medical practice. From the chemical point of view, chloroquine derivatives are weak bases due to the presence of basic side chains, and that's why they accumulate within acidic vesicles, mainly the lysosomal compartment, and this is very critical in their mechanism of action. And this is explained why it leads to eye toxicity, because it accumulates in the lysosomal compartments and bind to melanin in the RPE. Both of them, both hydroxychloroquine and chloroquines, absorbed in the upper intestinal tract, and this explains why the side effects, GI side effects like nausea and vomiting, are the most common side effects of these agents. Their half-lives are in general long. Due to large volume distribution, the blood can reach 40 to 60 days. Chloroquine has more half-life due to larger volume distribution. That's why chloroquine is associated with more eye toxicity, higher risk of eye toxicity compared to hydroxychloroquine. Both of them are cleared in the kidney function, so renal clearance is very important clinical consideration. Both of them cleared in the renal circulation. So any patient with impaired renal function or kidney failure can lead to decrease the clearance rates of these agents, which lead to increasing the bioavailability of these drugs, increasing the risk of toxicity. That's why when you screen a patient with hydroxychloroquine, you should order for the patient renal function test, or the baseline of this patient if he has impaired renal function or normal function test. Hydroxychloroquine binds very strongly to melanin, and that's why it can deposit in melanin containing tissues like skin. That's why it is used for skin manifestations. Also, it binds to melanin in the RBE, and this explains why eye toxicity happen. Both of them, hydroxychloroquine and chloroquine, are substrates for cytochrome B45, which is a known system for the metabolism of the drugs. And this explains why hydroxychloroquine and chloroquine can interfere with many other drugs. This is especially important from ophthalmic point of view when you have a patient using hydroxychloroquine with tamoxifen, which is agent estrogen receptor agonist used for cancer therapy, lead to increased toxicity of the eye due to this synergistic inhibition of lysosomal enzymes in the RBE cells. And they recommended that the combined use of tamoxifen and hydroxychloroquine should be limited to 6 months. Also, this explains why concurrent use of chloroquine with digoxetine can increase the plasma concentration of digoxetine 4 times. And this is also very important in cardiac patients. Also, hydroxychloroquine increases the levels of metoprolol through the prevention of its metabolism by competing the same cytochrome enzyme. And this is also very important for cardiac patients. These agents, hydroxychloroquine and chloroquine, inhibit autoimmunity. Many studies suggest that these agents inhibit lysosomal and autophagosome function, and therefore it inhibits immune activation. Also, many studies reported that they interfere with toll-like receptor signaling and cyclic GMP synthase activity. Also, they inhibit the production of interleukin-1, interleukin-6, TNF-alpha, and interferon gamma by mononuclear cells, and that's how they inhibit immune activation. Hydroxychloroquine is considered as the general bottom line that hydroxychloroquine is safe to use during pregnancy and breastfeeding. Both chloroquine and hydroxychloroquine cross the placenta, also hydroxychloroquine across the breast milk. However, the current guidelines, they strongly recommend maintaining treatment with hydroxychloroquine during pregnancy in patients with an autoimmune disease. Even that, some data suggest that hydroxychloroquine during pregnancy is protective against congenital heart block in infant due to possible reduction in the expression of type 1 interferon. Most common adverse effects, as we said earlier, are gastrointestinal manifestations like nausea, vomiting, diarrhea, and abdominal discomfort. And this is explained by that both hydroxychloroquine and chloroquine are mostly absorbed in the upper GI tract. Also, one of the common side effects are myopathy, hydroxychloroquine-associated myopathy. Rarely, also hydroxychloroquine can cause prolongation of QT interval, leading to cardiotoxic effects. However, the most severe complication is the development of retinopathy. And this retinopathy is irreversible, and we'll talk extensively about hydroxychloroquine retinopathy, which is the main topic of interest in this lecture. And this retinopathy is more common with chloroquine due to a larger volume distribution, as we said previously. Most of the world now is using hydroxychloroquine. However, chloroquine is still used in Africa for malaria agents. Hydroxychloroquine retinopathy is very important because it's irreversible, not treatable. However, if you recognize earlier damage before the changes in the RBE, you can preserve the central vision of the patient. This is why the screening is very, very important. Both these drugs, hydroxychloroquine and chloroquine, can cause retinal damage by disrupting the lysosome degradation photoreceptor outer signals in the RBE, which is a very important step in the visual cycle. And this leads to an increase in the lipofuscin RBE cells and therefore photoreceptor degradation. As we said previously, that both agents are weak bases which accumulate in the acidic environment like lysosomes. The prevalence of hydroxychloroquine retinopathy following long-term use more than 5 years is about 7.5% in the USA, 6.3% in the UK, and this depends on the dose of duration. The longer the duration, the higher the dose, the more percent of the patient with hydroxychloroquine retinopathy. It can reach 20 to 50% of the patient after 20 years of the therapy. These are the most important 5 factors that can increase the risk of developing hydroxychloroquine or chloroquine retinopathy. Very, very important, very high yield and very common questions in the exams. There is a rule, 5-5 rule. The drug dose of more than 5 milligram per kg for more than 5 years is considered a main risk factor. So the first risk factor is a drug dose of 5 milligram per kg or chloroquine 2.3 milligram per kg per day. Also the prolonged use of the drug more than 5 years. The third one is high cumulative dose more than 1 gram, more than 1000 gram for hydroxychloroquine and 460 gram for chloroquine. Also impaired renal function like stage 3 to 5 chronic kidney disease, and we explain this why, because both hydroxychloroquine and chloroquine are cleared in the renal circulation, and decreased renal function lead to increased bioavailability of these drugs. Also, the co-medication with tamoxifen for more than 6 months increase the risk of retinopathy 5-fold. And we explain that both of the agents, if they given together, they will lead to synergistic inhibition of lysosomal enzymes in the RBE. These are lesser factors that contribute to the hydroxychloroquine Plaquenil retinopathy. The first one is the age, because we know as people aging people have less metabolism function, both liver and kidney. That's why they are more prone to the retinopathy. Also liver disease, patients with liver diseases, because as we said previously that hydroxychloroquine and chloroquine are metabolized mainly in the liver in the cytochrome 450. Regarding genetic factors, is a controversial risk factors. Some study reported that patients with ABCA4 gene mutations have more risk to develop Plaquenil retinopathy. However, other studies reported that patients with mutations in this gene could be protective for them against developing hydroxychloroquine. However, these genetic factors could explain the difference in the disease presentation between European and Asian eyes, because as we will see later in this lecture that European patients usually present with parafoveal presentation, parafoveal changes in the RBE and outer retina. However, Asian people present with paracentral, even near the arcades. And this could be explained by the genetic factors differences between these two races. Classic features in summary. Classic features for hydroxychloroquine or Plaquenil in summary. Usually patients are asymptomatic, especially if they were started on hydroxychloroquine or chloroquine recently. However, later in advanced stages, they could develop paracentral scotomas with decreased central vision and reading difficulty. Regarding the signs, the early signs of toxicity, we will talk deeply in these signs. However, in general, they can develop bilateral paracentral visual field defects and inner segment ellipsoid zone loss in the paracentral location, parafoveal or paracentral location, which appear as a flying saucer sign in OCT. We'll talk about this sign later also. When also there is continuous exposure for the drug hydroxychloroquine or chloroquine, will lead to the typical pictures of bullseye maculopathy, which is also appear in this image. For the spectral domain, OCT very important in the diagnosis of hydroxyplaquenil retinopathy, one of the gold standard diagnostic tests. And we'll talk about these tests all deeply in this lecture. We use always in the screening for patients of hydroxychloroquine spectral domain OCT, which can appear, can show, if we see in this region, localized thinning of the photoreceptors layers in the parafoveal region, or localized thinning here of the photoreceptors ellipsoid zones in the paracentral area, which are strong indicators of toxicity. So if you see these localized thinning of the photoreceptor layers, this patient is having early stage of retinopathy, and you should discuss this with the primary medicine doctor for the patient. Also in this picture we see more advanced stage of hydroxychloroquine retinopathy. As we see here, there is localized parafoveal thinning of the photoreceptor layer ellipsoid zone, and here also is noted. One of the earliest signs for hydroxychloroquine or plaquenil retinopathy is moth-eaten photoreceptors appearance. This was reported by Dr. Stepin in 2009, in which he was first described this sign, moth-eaten appearance of the photoreceptor inner segment and outer segment junction. As you see here, there is this moth-eaten appearance of the ISOS junction due to preferential loss of cone photoreceptors, and this is considered one of the earliest signs for patients with plaquenil retinopathy, and he described it as preclinical stage toxicity. You cannot see on your exam, you will not see any findings in the macula. However, in the OCT you can detect this moth-eaten appearance of the ISOS junction. Spectral domain OCT early changes. You need to be careful during examining these patients because you can detect the retinopathy very early on spectral domain OCT. You can here highlight the changes, attenuation, like thinning in the ellipsoid zone in these patients. Here, thinning, attenuation, or depression in the ellipsoid zone of this patient, along with disruption in the interdigitation zone. And this patient is having normal visual field. So you can detect these changes in the OCT before the changes in the visual field. Also, as you see here, there is depression, thinning, attenuation in the ellipsoid zones with interruption in the interdigitation zone. And this is also the same in all pictures. All these patients have are having normal visual field. However, they have changes in the interdigitation zone and the ellipsoid zones with depression and attenuation and thinning. And these are considered one of the earliest, very earliest signs seen in Plaquenil retinopathy. Also, this was described in one of the studies as a reflectivity sign. As we see here, one of the earliest signs, this patient is having paracentral scotoma in visual 10-2 visual field in both right eye and left eye. And in OCT, he has decreased reflectivity, reduced reflectivity of the ellipsoid zone compared to the foveal, in the parafoveal region compared to the foveal ellipsoid zone, which lead to false higher reflectivity of the ellipsoid zone in the foveal region compared to the parafoveal region. And this is one of the earliest signs also seen in the spectral domain OCT. Also, we see as interruption of the interdigitation zone in the parafoveal compared to the foveal. These both changes can be seen in the early OCT. And this patient, he has scotomas, diffuse scotoma, and visual field with also it changes, as we said earlier, reduced reflectivity in both in the ellipsoid zone parafoveal compared to the foveal, also attenuation and disruption of the interdigitation zone in the parafoveal region compared to the foveal region. And also they reported in this study that there is 100% thinning of the outer nuclear layer, and we see here thickening of the Henle fiber layer due to thinning of the outer nuclear layer. These are very early signs of Plaquenil retinopathy, and I'm telling you these signs to help you and detect people with retinopathy very early. As we see also here, flying saucer sign or sombrero sign. Sombrero due to this sombrero hat, and this is like the flying saucer sign. And this is explained very early and can be seen early in retinopathy, in Plaquenil retinopathy. And this is explained by that this parafoveal loss of the inner segment outer segment region with the preservation of the foveal central outer retina, leading to sinkhole effect, what they are telling as sinkhole effect due to loss of the parafoveal photoreceptors with preservation of the central foveal outer retina, leading to the characteristic of flying saucer sign. And as we said earlier, that this is not the earliest sign of the Plaquenil retinopathy. There is one sign described by Dr. Stephen, with moth-eaten appearance of the ISOS junction, which considered the earliest sign of Plaquenil toxicity. Finally, if the patient continue to take Plaquenil or Chloroquine with continuous drug exposure for long time, it can lead to bullseye maculopathy due to the loss and degeneration of the photoreceptors with sparing to the foveal center, leading to the characteristic sign bullseye maculopathy. And the importance of the screening, they are telling that we should never ever see a patient with bullseye maculopathy. The second investigation of choice is fundus autofluorescence. As we said previously, that both chloroquine and hydroxychloroquine cause damage to the lysosomal degradation of photoreceptor outer segments in the visual cycle, which lead to increase in lipofuscin in the RPE and therefore photoreceptor degradation. Fundus autofluorescence test assess the lipofuscin fluorescence in the RPE through using 488 nanometer blue wavelength blue light. So, fundus autofluorescence image can reveal early parafoveal in European eyes or extramacular uh, retinopathy in Asian eyes as area of increased autofluorescence, which could precede the thinning on the spectral domain in OCT in some of the studies. Like this study published in 2012, they report that fundus autofluorescence can detect early damage that precede even the thinning on spectral domain OCT. And why you see area of increased autofluorescence? Because there is increased lipofuscin in the RPE, and this is as we said earlier. However, later on, RPE loss appear as a dark area due to reduced autofluorescence. As we see in this image, increased fluorescence paracentrally in a patient in European from European race. However, in this fundus autofluorescence image, we see area of increased fluorescence extramacularly near the arcades in Asian eye, and also here we see area of reduced autofluorescence, which explained by RBA loss as a later stage from the increased autofluorescence. The third investigation of choice for patients with using hydroxychloroquine is visual field 10-2, and you can see on this test the paracentral scotomas. The most frequent area of the retina showing early damage is the inferotemporal quadrant. This can be explained by melanin distribution, and this leads to characteristic superior nasal field effect, which can be seen in the Humphrey visual field 10-2, and we ask for 10-2 in patients with parafoveal presentation like European patients. However, in patients with extramacular, we can ask for 20-2. With patients in from European descent, we ask for Humphrey visual field 10-2. We can see paracentral scotoma, especially in the superior nasal field, because that the most frequent area of the retina damage is inferotemporal. As we see in this patient is having SLE and was given Plaquenil for a long time. The OCT is showing, as we discussed previously, attenuation, and depression of the ellipsoid zone, along with interruption in the interdigitation zone in the parafoveal region, with the preservation in the central foveal photoreceptors, leading to the characteristic sign of flying saucer sign. On visual field 10-2, there was superior nasal visual field defect. Also, multifocal ERG is used as an investigation for detecting Plaquenil retinopathy, and studies reported that multifocal ERG is similar in sensitivity to visual fields and can provide objective confirmation of any suspected field loss. However, the main drawback of multifocal ERG that requires well-calibrated equipment in addition to experienced physician or technician to perform and interpret these results. As we see here, this multifocal ERG showing parafoveal attenuation or decreased amplitude in the parafoveal region in a patient using Plaquenil. Also, these are variations of multifocal ERG. For example, this ERG is normal in a patient using Plaquenil. However, in this multifocal ERG, if you focus on this ERG, you will see reduced amplitude loss here and here in the pericentral area, and figure C is showing that there is central amplitude loss in a patient using Plaquenil. Finally, this figure showing generalized amplitude loss in a patient using Plaquenil, which represent advanced stage and irreversible damage for this patient. Recently, studies have been talking about in-face OCT, which is emerging technique that combines spectral domain OCT and transverse confocal analysis. This in-face OCT allows for assessing the structural changes in the retina in coronal plane, and also it allows for quantitative analysis. In any area of photoreceptor defect, it will appear like P10 bronze appearance. For example, in this patient, here you can see in face plane, coronal plane of both retina and choroidal layer. This is in baseline, this is in follow-up. You can see any area of photoreceptor defect as a P10 bronze appearance. Also, it allows for quantitative analysis. If you see here, initially as a baseline it was about 6 millimeters square. However, in follow-up, the patient was having a reduced number of photoreceptors to about 5.28 millimeters square, and this explains that this patient is having early sign of toxicity, or later early sign of toxicity. So in-face OCT is an emerging technique that it can help you also in detecting retinopathy. Also, some studies reported the role of OCT angiography in patients with Plaquenil retinopathy. The findings that you can see in those patients are decreased vascular density of both deep and superficial capillary plexus, as we see here, and follow up. Also, there is increase in phase zone, foveal avascular zone size. Also, there is signal void in choriocapillaries. These are the changes that can be seen in OCT angiography, which is non-invasive, dye-free technique, and it also helps you in detecting and following up patients with retinopathy. However, the main limitation of OCT angio, as we know, is the limited field of view. For Asian population, as we said earlier, due to genetic factor differences between Asian and European people, patients from Asian descent, usually they have extramacular presentation of Plaquenil retinopathy. So in order to discover that or detect early changes, we need to use 30-2 visual field, or even 20-2 visual field. However, 10-2 we should use it only for patients from European descent, because they have parafoveal presentation. And Asian people, they have initial damage in the more peripheral distribution, as we see here in this fundus autofluorescence imaging, showing increased autofluorescence along the inferior arcade in both eyes. And we see here scotomas in the third -2 30-2 visual field, and in the OCT we see a small image. However, we see here attenuation of the ellipsoid zone along in the interdigitation zone in the peripheral area, and as we go to the inferior scans, this damage will be more manifested. This patient is from China, Chinese patient with SLE disease, also using hydroxychloroquine for 10 years. When we did for the patient 30-2 visual field, we noticed partial ring scotoma and the multifocal ERG showing reduced signal or reduced amplitude in the inferotemporal area paracentrally. You see here, however, the central area very normal amplitudes. And fundus autofluorescence showing increased fundus autofluorescence here extramacularly with reduced autofluorescence near the arcade, which explain which means late RPE loss. as we say that RBA loss appear as reduced fluorescence compared to the earlier damage. OCT showing here the same attenuation of the ellipsoid zone along with disruption of the interdigitation zone and even thinning of the outer nuclear layer in the peripheral OCT. However, the foveal area is preserved. Last but not least, the corneal changes from hydroxychloroquine or chloroquine. As we know, this is a typical picture of cornea verticillata or vortex keratopathy. It's very common with amiodarone and is typically questioned for amiodarone. However, hydroxychloroquine also and chloroquine are associated with this vortex keratopathy, which is more common with the chloroquine. However, this cornea verticillata is a not direct marker for retinal damage. This is not associated with retinopathy. Also, they are not associated with visual loss, and these also changes are usually reversible. In summary, findings of the OCT and fundus autofluorescence, as we said earlier, that OCT can detect attenuation and loss of the ellipsoid zone. Also, outer retinal layers loss with fovea sparing leading to the flying saucer sign or sombrero sign. Also, attenuation, thinning of the outer retinal areas. Also, thinning of the outer nuclear layer, which was reported 100% in patients in one of the study. Loss and disruption of the interdigitation zone. Also, it has parafoveal presentation European eyes and extramacular or pericentral presentation in Asian eyes. And for fundus autofluorescence, as we said earlier, that initially they have a hyper autofluorescence. However, with time, due to RBA loss, it can lead to decreased fluorescence on the fundus autofluorescence image. Also, it show very clearly late stages, advanced stages of Plaquenil retinopathy like bullseye maculopathy pattern. Here in these examples, I will illustrate some of the examples of progressive changes from same patients. They were follow up or lost to follow up, and then they present later on with more progressive changes. As we see in this patient, this image showing normal fundus photo with the normal OCT and normal visual field. However, with time, the patient started to develop parafoveal changes, as we said previously, in ISOS junction, also paracentral scotoma and 10-2 visual field. And this patient from European descent. With time, the patient was having this severe more severe loss in the parafoveal outer retinal layer with relatively preservation of the central photoreceptors leading to the flying saucer sign with almost complete ring scotoma or partial ring scotoma. With time, lead to advanced loss of the outer retinal layers with complete scotoma in the visual field and loss of the photoreceptors, and this patient will have very poor vision. And this patient also from European descent, showing here initially one scotoma progressively increasing with time. The fundus is normal, however, multifocal ERG showing here reduced amplitude in the parafoveal region, and the OCT showing the very early signs of decreased reflectivity of the ellipsoid zone and disruption of the interdigitation zones in the parafoveal area. In addition, fundus autofluorescence showing increased fluorescence parafoveally. However, this patient is advanced stage of Plaquenil retinopathy, showing severe disruption in the photoreceptors ISOS junction in the parafoveal area with atrophy of the retinal layer. Here also we see increased choroidal layer stress due to retinal layer atrophy. Also we see here bullseye maculopathy appearance in both fundus photo and fundus autofluorescence imaging, and this is very advanced stage of complete disruption of the outer retinal layer structures in the spectral domain OCT with bullseye maculopathy in both appearance, in both imaging, fundus photo and fundus autofluorescence imaging. This also example of a patient with very subtle changes in the OCT, representing reduced reflectivity in the ellipsoid zone along with disruption of the interdigitation zone in the parafoveal region compared to the foveal area with complete normal visual field 10-2, and the patient lost to follow-up for 7 years. Then he presented with more disruption in the photoreceptor ISOS junction in the parafovea along with thinning of the outer nuclear layer, leading to the characteristic flying saucer sign in the OCT and bullseye maculopathy sign in both fundus photo and fundus autofluorescence image. And these are also changes, these are subtle changes from patients starting only image after 6 months from hydroxychloroquine large dose. He was having, these are subtle changes of parafoveal ellipsoid and interdigitation zone changes with time, as we see here, flying saucer sign, and with time lead to complete loss of the outer retinal layer, mainly in the parafoveal area. So these are changes, progressive changes of Plaquenil. Regarding the changes after cessation, this is very unique paper published in the British Journal of Ophthalmology 2014. They discussed the types of changes that happen after stopping Plaquenil or chloroquine, and they divided this into 2 types. Mainly the first type is non-progressive retinopathy, which happen in limited parafoveal retinopathy. If you detect patient with subtle changes in the parafoveal region on OCT and you stopped the medication for him or for her, most probably the patient will not have any progression or any changes after this cessation. However, otherwise, the patient will have progressive retinopathy, and this explained by progression of retinal degeneration along with vision deterioration. Also, there is reduction in the retinal thickness due to increased area of RBE loss and photoreceptor loss, as we see here, decreased fluorescence in the fundus autofluorescence image from this picture to this picture due to reduction in the retinal thickness and RBE loss, photoreceptor loss. Also, what they described very novel description that 50 to 60% of the patient will develop cystomacular edema or epiretinal membrane. As we see in this image, this is cystomacular edema along with epiretinal membrane, and the mechanism how CME or epiretinal membrane develop is not well known, is not clearly understood, and they report that the therapy of the cystomacular edema is usually of limited benefit in these patients. Now we'll talk about very important part in this lecture, which is the screening. How you will screen this patient and how frequent you will screen and what tests you will do. These are the latest guidelines from the Royal College of Ophthalmologists published in by journal in 21. They said any patient with hydroxychloroquine, you should follow this flow chart. If the patient has no additional risk factor, you should screen the patient after 5 years of the drug therapy. There is no baseline testing. Also, they said, however, if the patient has any additional risk factors that we talked about previously, concomitant use of tamoxifen or impaired renal function, stage 3 to 5 renal disease, or the dose is greater than 5 years, or there is chloroquine use, which is associated with higher risk of eye toxicity, you should monitor these patients after 1 year of the drug therapy. And what you will use for them. You will start your screening by spectral domain OCT and wide field fundus autofluorescence image. As we see here, there is no ham-free visual field test in the beginning. If both of them are abnormal, this is definite toxicity. Definite toxicity means 2 abnormal tests. Possible toxicity means 1 abnormal test. However, if both of them are normal, this is a normal exam, and you should repeat screening those patients, monitoring them annually. If you have one of them is abnormal, spectral domain OCT or wide field fundus autofluorescence OCT, fundus autofluorescence image are abnormal. One of them, if one of them is abnormal, you need to do ham-free visual test. If from European descent, you will do 10-2. If from Asian descent, you will do 30-2. If this is normal, you need to perform multifocal ERG, and if the multifocal ERG normal, you need to repeat this monitoring annually. However, if ham-free visual test is abnormal, this is definite toxicity. As we said, 2 abnormal tests, either spectral domain OCT or fundus autofluorescence plus ham-free visual field test means definite toxicity, or ham-free visual field test is normal, however multifocal ERG is abnormal. This is also definite toxicity, which is 2 abnormal tests. If you have a patient with definite toxicity, you should discuss with the prescribing physician about the termination of hydroxychloroquine or chloroquine to prevent irreversible retinal damage. The key changes that happened to the 2018 recommendations from the Royal College of Ophthalmology, they said that baseline testing is not recommended for the initiators of hydroxychloroquine or chloroquine, because a large audit done in the UK for patients had taken hydroxychloroquine for less than 5 years found that none of them they had abnormality on baseline testing that precluded continuation of the treatment. In addition to that, significant proportion of the new initiators are no longer taking the medication at 5 years due to insufficient clinical response or adverse effects. Also, they found that baseline assessment represent more than half of all hydroxychloroquine monitoring appointments in one of the UK audits, which is very large percentage of the appointments. Also, they said that ham-free visual field testing is no longer recommended as a first-line monitoring testing. As we said, the first-line monitoring testing is spectral domain OCT plus minus fundus autofluorescence. And they explain that why visual field is no longer recommended as a first-line monitoring testing, because it's demanding, time-consuming, and often unreliable. And they found in one of the large UK audits that 33% of the tests are unreliable due to different reasons: fixation losses, false positive or false negative results, with the 25% of poor quality. Also, structural changes in spectral domain OCT or fundus autofluorescence can precede visual field defects that are detectable on Humphrey visual field testing. Also, they said that the requirement for toxicity criteria abnormalities on one subjective test and one objective test is also no longer relevant. There is no requirement to do one subjective test and one objective test. It's okay to do two subjective tests like that. However, the definition of toxicity, possible toxicity, as we said earlier, one abnormal test result, definite toxicity, two abnormal test results remain unchanged. And this is the toxicity definition from the Royal College. No toxicity, there is no any changes of hydroxychloroquine retinopathy in OCT or fundus autofluorescence. Possible toxicity, one of OCT or fundus autofluorescence represent typical signs of hydroxychloroquine retinopathy. However, visual field and multifocal ERG are normal. This represents one abnormal test, which is possible toxicity. Definite toxicity, two of them are abnormal, OCT and fundus autofluorescence, or OCT or the fundus autofluorescence confirmed with visual field or multifocal ERG with finding corresponding to the hydroxychloroquine retinopathy. This is considered as a definite toxicity. And they recommend that patients with possible hydroxychloroquine retinopathy, they should continue the drug treatment. However, patients with definite hydroxychloroquine retinopathy should discontinue the drug treatment, and this is after discussion with the prescribing physician. And they said that any patient with hydroxychloroquine, definite hydroxychloroquine toxicity, should inform the driver and vehicle licensing agency, because it's not allowed for him to drive until he do a Serhan visual field. Regarding the safe dose, the current evidence suggests that the highest risk of hydroxychloroquine retinopathy when you take more than 5 mg per kg per day. This is very important because many patients they are taking 400 mg of hydroxychloroquine per day, which is higher than the recommended dose for any patient who weighs less than 80 kg. So you should discuss this with the prescribing physician that this patient weight is less than 80 kg. We can reduce the dose of the hydroxychloroquine to keep the patient safe and prevent irreversible retinopathy. You can memorize these guidelines as I said previously, 5x5 rule. Always keep the dose less than 5 mg per kg per day, and always start monitoring after 5 years of drug use if there is no additional risk factors. However, if there is additional risk factors, you should monitor the patient after 1 year. Also, so this is the 5x5 rule for safe dosing in patients with hydroxychloroquine. Last, I will talk about the tests that are not recommended for screening, which is published in Ophthalmology in 2016. They say that fundus examination and photography are not recommended for screening because they will not show any early changes. They will only show late changes. Also, they didn't recommend time domain OCT due to poor resolution. Also, fluorescein angiography is not recommended for screening because it can reveal RB loss. However, this is a late stage from the retinopathy, so the test is not recommended for screening. Also, full field ERG is a global retinal function, and it will not reveal any earlier changes. It will show only late changes. Amsler grid is inconsistent from patients. They can make error. Also, some patients they have already congenital color blindness. So it's unreliable to do it for screening. Also, color vision testing, as I said, because many patients color blind or color deficient, not specific nor sensitive. Also, ancillary grade is inconsistent between patients and unreliable. Finally, electrooculogram also is not reliable as a test for screening. I hope you find this lecture is very useful. I tried to discuss everything from A to Z. And finally, this is the final uh, advice from Dr. Uday Devgan, thanking him how we are taught to measure success early as a surgical volume and income job title. However, this is a better measure of success, relationships, health, enjoyment time. As you see, this wisdom you will take it while you are becoming more elder. Okay, thank you all. I hope you get benefit from this lecture. Thank you all. See you later.